title slide that says cardiovascular care?
Yes.
Perfect. The computer is cooperating today. It's going to be a good day. Well, we are going to talk about the cardiovascular hypertension guidelines that came out August, October, one of the two. I lose track. Time is just not have the same meaning after COVID. I just cannot keep track of what time it is. But we are going to talk about the 2025 hypertension guidelines. I know the lipid guidelines have come out. I have not had a chance to dive into them, so I will bring those to you probably at our next cardiovascular hypertension webinar, but those I do not have for us today. What we're going to do today is kind of dive in a little deeper. We kind of did an overview of what all the changes were. I think it was the session before last. And so today we're going to get a little deeper into it, get a little bit into the behind the reasoning of it, and do a few little thinking exercises just to keep you guys awake right after lunch. So this is kind of our agenda for the day. And feel free to ask questions, share your perspective or thoughts. Carrie is going to be watching the chat. So if you can't unmute, feel free to share via chat and we will capture your questions and input that way. Here's some of our learning objectives. We don't have continuing education credits, but by using these through your your licensing entity, sometimes you can get credits that way. So that's why I put the learning objectives in the slideshow. So let's get started. We have a habit in the health center world of kind of looking at blood pressure control through the lens of UDS, which there's nothing wrong with that. That's what we're measured on. That's what we report on. It's standardized across the United States. Everybody in the health centers are reporting that way. It's very useful for comparing and looking at things. You know, it is most recent blood pressure 140/90. And I know you guys know this, but the reason I'm bringing it is I've had a few conversations with people during UDS reporting a little bit, maybe in December, around the hypertension measure. And so I just wanted to touch on this a little bit, but it is in the criteria that if you do multiple blood pressures in the office during a visit, it is you can use the lowest on that same day. Sometimes in your EHR, it'll take the last one done. That's just a software function, but in the manual, it does say that the lowest one does count. We are expected to exclude any that are measured in the emergency department or inpatient readings. I don't know that anybody is doing that. But one thing I want to caution is self-measured blood pressures by patients. If a patient brings in a series of readings for you, and you look at them, those you cannot use for UDS reporting. If they're doing it at home and it's going into your EHR under remote patient monitoring, yes, those can. If you are doing a telehealth visit and the patient puts on the cuff and does the thing, and then the provider can see what that blood pressure is, or the nurse, whoever is from the health center that's doing that piece of the visit, yes, if you see it done and you see it on the monitor, you can put that in there. But just a patient bringing and presenting that information, those are not supposed to be used for that. And I did pull, it's really tiny. It's hard to see maybe on the screen, but this is in the specification guidance. That's where you can find that. And I'm not saying any of you are doing anything wrong with this. I just had a few questions and I wanted to make sure I got this information to everybody. If you're looking for this in the 2025 UDS manual, it is on page 133 of the 2025 UDS manual. So just a little bit of a review of what's in the 2025 hypertension guidelines is that the blood pressure goal for most adults is 130/80, which that didn't technically really change a whole lot from the 2017, but it's just become more prominent in the recommendations. They have shifted from the ASCVD 10-year risk score to the prevent risk score. And keep in mind, these risk scores are only useful on patients who do not already have cardiovascular disease. If they already have cardiovascular disease, it is not relevant because they already have it. What the screening tool is looking at is predicting the likelihood of having cardiovascular disease. If they already have it, it's 100%. They've got it. So that's one other thing to kind of keep in mind. The guidelines really promote early use of treatment to control blood pressure and manage it at 130/80. And they really promote using single pill combinations. If you have a patient that needs to be on multiple blood pressure lowering medications, if you can get those into a single pill, it really helps the patient manage those medications, and it helps with their ability to adhere to the treatment program. And in the 2025 guidelines, there really is an emphasis on patients monitoring their blood pressures, team-based care, not just in your entity, but team-based care, including and wrapping in metabolic endocrinology, that piece of the syndrome, and nephrology, the kidney part of the cardiac kidney metabolic disorder. So those are just some of the key things. So then this is where I just want to think. Nobody's doing anything wrong. I just want to kind of think for a minute. So our target for our UDS is 140/90. Our American Heart Association, their target is 130/80. Which do we choose to work towards? And are we educating patients? Do we choose how we define controlled hypertension by UDS reporting criteria or by professional organizations that set or care standards? And that's just to think for a minute. We have used 140/90 since I came into nursing in the 90s. And with these new guidelines, it's been proven that the earlier that blood pressure can get controlled at a lower criteria, the less long-term damage there is to the heart, the kidneys, and the metabolic system. So I just kind of challenge a little, because that has been ingrained into all of us. My entire life, 140/90, that's high blood pressure. That is going to be a big thing to shift. And what piece do we play in advancing that new knowledge of how elevated blood pressure causes damage much earlier than we previously understood? So just kind of tease that thought a little bit. What do we follow for mammograms? When do you start mammograms at your health center? What age and what frequency? You start at age 40 every year? Is that what you recommend? Or do you screen beginning at age 50 every 2 years? Neither is necessarily wrong, but one of those is the USPTF and the other one is UDS. And so I'm just trying to draw kind of a correlation that there can be different criteria, and just challenge you to think through, what do we want our hypertension care to look like? I'm not saying anybody's doing anything wrong. I'm not saying either one of those is wrong, but because we've been in the habit of 140/90 for me, most of my career, from my adulthood, 140/90 is just the default. It's the go-to. And I believe strongly that our patients have that same mentation. I mean, they're going to say, well, my blood pressure is not elevated. It's good. It's 130/78. Well, yeah, that's good, but we don't want it to go any higher. The reason you don't want to go any higher is we don't want them to begin to have early damage. So, anybody have any thoughts on that?
This is Brenda. I think a lot of times the USPS, whatever guidelines, that's what HEDIS seems to follow. And so if your practice is working towards HEDIS, um, could be the stricter of the two. And you're probably not going to be um, you're better off going with the stricter, instead of having two sets of rules, it's better to be more limited than to have the higher, because the probability of the UDS at some point in the very near future will be matching the government preventative care screening guide. That's my assumption, I guess, when I think about it. So, and then you have MIPS in there, and MIPS usually is similar to the HEDIS guidelines. So that's my level of thinking as to when it comes to the government, stricter is better.
Yeah. Has anybody in their health center made a shift away from, um, or let me ask it this way. Is there anybody in the health centers who has set out to educate patients on the new guidelines being below 120/80 as where ideal blood pressure is? Or educating about the new tiers for the blood pressure um, levels, I guess, is stages, phases, stages. I'm gonna throw KDHE out here. They have some really cool magnets if you want to do something around doing education with your patients. They have big and small magnets. I've gotten them at the last couple of conferences, and I don't have any on my desk because I moved, and so my grab things aren't where they used to be. But it's a little magnet, and it's shaped like the state of Kansas, because we're pretty much a box, but it's the state of Kansas, and it's got the different tiers. And if you're interested in doing something with your patients as kind of a community education sort of thing, I would suggest getting with them and getting some of those magnets, because they will make those available to you. If you need me to connect you with Brittany at KDHE, I'm more than happy to do that. So. Moving on. My slides don't want to advance. There we go. So, oh, Heather's back on measuring blood pressure again. We've talked about this several different times on measuring accurate blood pressures. And I know I've asked it in a couple of different meetings, but we have different people come to different meetings. So, do you have a process, or do you know if there's a process for validating any of your devices that you're giving to your patients, or your patients are using, or if you're recommending blood pressure monitors for patients to use? Do you have lists of validated devices, and make sure that they're using the correct size and waiting between repeated blood pressures? You ever see the patient where, and maybe it's a family member, I guess I should say family member, or somebody they've got that blood pressure cuff on, and they push the button, and they don't like that one, so they push it again. And then they push again. They're doing 5 blood pressures right back to back. Do we have anything for them around that? And if so, would you be willing to share that with the network, with the people on the call? You can send it to me, and we can share it with the follow-up email that comes out. This self-measured blood pressure, 2 readings, one in the morning, one in the evening for 7 days. That's going to come up a little bit later in the slides. But that's the recommendation for somebody that you are doing um, lifestyle modification for in the lower tier of blood pressure concerns. So that's one thing I wanted to make sure I got in the slideshow for you guys. And then the bullet point about documenting that blood pressure. It should not probably go into your vital signs flow sheet because those don't meet the criteria for the UDS hypertension measure. But where do you document those in your EHR? I would kind of guess that you guys want them in there or your providers want them in there, but where do you put patient blood pressure lists in your EHR? And if you've been putting them in your flow sheets, don't worry about that. We'll go forward from here. But does anybody have a way that they kind of regularly put patient tracked blood pressures in that patient's record? Or is it more of the patient brings in the list, the provider looks at it, makes a few comments, maybe notes it in their narrative note, and then hands it back to the patient? Look at it, make a notation in the chart, and then it goes back home with the patient. I see a thumbs up on that. Okay. Just wondering if anybody else had any other thing they were doing with their patient measured blood pressures. All right. So we are going to look at the standardized, this is a really abbreviated version of the treatment algorithm. With the handouts or with the slideshow and the recording that's going to come out tomorrow probably, there is a PDF with this algorithm kind of in a picture that I found out. It's out of the American Heart Association little booklet thing. I just put it on a Word document and made it a little bigger. So that will be in the packet that comes when the slides come. But
Hey, Heather.
stage 1. Yes.
So Shauna had put in the chat to your question before, the nurse does put all the BP in the patient chart, then uploads the document into the patient chart at her clinic. So
Okay. When you say put it into the chart, are they putting it into the vital signs flow sheet, or that document is going into the patient's chart?
Both. So doctor
Okay.
makes you put it all in the vital signs part, but the doc puts all the vital signs in there, or the blood pressure's in the vital signs part, but the document also has to go in the patient chart.
Okay. Oops. Click too fast. Anybody else do anything different with patient measured blood pressures that patients bring in or send in?
We just scan ours into our chart. We don't put them in the vitals area. And then with our RPM people, we take those numbers and we have those scanned in each month as well.
Okay. On your RPM, are those patients, is that automatically going into your EHR and you're adding them in, or are those measurements that the patients are doing and then documenting and bringing to you?
So with our RPM company, it sends it directly to the computer of whoever's linked to that program. It's like we get emails and it makes like a log sheet of all their blood pressures. And at the end of the month, we have that log sheet and all of their information gets scanned into their chart.
Okay. All right.
What we found was when we were entering the blood pressures in the vital signs part, it helped our UDS numbers come up. Because those blood pressures at home tend to be better than when they come into the clinic.
Yeah. You might check that section in the UDS manual about patient measured blood pressures and when they are eligible to be included in the UDS data. So the RPM, Joanne, the RPM, that is not a concern with the UDS data. I believe what I say, it was page 133 of the 2025 UDS manual that those reporting specifications around appropriate blood pressure measurements for reporting were. So, and if anybody has, we can discuss that more if you guys want to, or I can discuss that with anybody offline if you want more around that. Whatever direction you guys want to go is fine with me. Okay. So stage 1 of the treatment algorithm is lifestyle and monotherapy. Stage 2 is a second agent, so that's 2 medications in a single pill capsule, single pill combo. I have to remember my different abbreviations I put on here. I use abbreviations so it fits and I forget what I'm trying to say. So our patients that have chronic kidney disease or diabetes, they tend to suggest prioritizing the ACE or the ARB medications. For resistant hypertension, they suggest optimizing the diuretic and adding a mineralocorticoid receptor antagonist. And then when your blood pressures aren't coming down, evaluate for a secondary hypertension or something that is, that also needs to be addressed in order for that blood pressure to come down. All right. You ready to, we're going to try something new. Sorry, guys. Allergies. We're going to try something new. I made a little quiz kind of as we're going to try out and see how to apply the new treatment guidelines for different patient scenarios. It's really tiny. It's just like, this patient has this blood pressure and this risk score. What do we do? So, Carrie, if you want to see if my Quizlet will work.
It should be
And
up.
everybody gets an A+ just for participating. So we'll give you a couple minutes. I will back the slides up so you can see what that algorithm was. Might help you with a couple of them. And if you don't know, just take a wild guess. We'll talk through them.
Answers are slowly coming in, Heather. So
Yeah. They'll take
really making
just a
them
little
think.
bit. It takes a little bit of thinking, but that's kind of today's focus is let's think about these new guidelines. And remember, I had the book for making these, so don't think that I knew all of this in my head without any help. We'll give it another 30 seconds. Okay. Let's go ahead and close the poll. And Carrie, I think you can share it with the answers. Is that right? Awesome. Okay. I'm going to sit sideways because my screen that's on is over here. So apologize for the side view. Question number 1. Which patient requires immediate medication initiation? The correct answer is the patient with the blood pressure. Let's see, that would be ABCD. Blood pressure is 132/82, and the prevent score is 9. And it's that score that bumps them up because the cutoff for the prevent is 7 or 7.5. And so that patient is going to get a single pill monotherapy because that risk score is elevated. If that risk score was not elevated, they could get the monotherapy as well as lifestyle, but they could also have the option to do just lifestyle. Any thoughts on that? That one's tricky. They're all kind of tricky because all these guidelines are a little bit tricky. Okay, question number 2. What is the primary management for a patient with blood pressure 142/92? Looks like everybody got that one correct. And one thing that I've noticed on these new guidelines is everybody gets lifestyle changes. Even the severe hypertension, probably hypertensive crisis, but you want to get them out of crisis first. But all the stages, stage 1, stage 2, severe hypertension, all of them get lifestyle changes. All right. Question number 3. A patient has a blood pressure of 136/86 and a prevent score of 3%. Lifestyle modification, 3 to 6 months of lifestyle modification. That's the flip of question 1, because the question 1 patient had an elevated prevent score and patient number 3 had a lower prevent score. So that's why patient number 3 has the option to do lifestyle changes without a medication at the start. But notice it's 3 to 6 months. It's not just turn loose. It's like come back and get rechecked. And if it's not improved, if that blood pressure hasn't come down, then it's indicated for monotherapy to start. Patient number 4. 42-year-old with a blood pressure of 134/84 today. Their BMI is 28 and they have normal labs. Lifestyle changes and recheck in 3 to 6 months. I don't think that starting a single medication is incorrect. That could be a conversation between the patient and the provider. Maybe they already have a relatively healthy lifestyle and they do need to have a medication, but probably would not start with a combination medication, depending on the other comorbidities going on. There may very well be good indications for that. This previously when we were under the 140/90, this would have been left as a normal reading. But now 130 to 139 over 80 to 89 is actually stage 1 hypertension. I think, I'm pretty sure. I still get them confused myself sometimes. So if somebody has if somebody has something in front of them that says that I'm wrong, please don't let me tell anybody something wrong. All right. Where are we at? Are we at number 5? A 60-year-old patient at a routine visit has a blood pressure of 188 over 114. They have no symptoms and they feel fine. It is severe hypertension and they need outpatient treatment, not sent to the emergency room. And this is one of the changes. In order to get sent to the emergency room, there needs to be an additional symptom of a target organ. And the reason for that is if that individual goes to the emergency room and they're treated as if it's a crisis, and their blood pressure comes down too quickly, they could actually have a stroke because of the decreased perfusion in the brain. So actually through the research they did between 2017 and 2025, they found that that actually was a concern to just based on the blood pressure reading to send them to the emergency room. Hypertensive urgency is actually no longer used. That is now an obsolete term. There's severe hypertension, which is that is a very high blood pressure, but they don't have additional symptoms. Hypertensive emergency, you have that high blood pressure, plus there's something else going on. So that is the difference there, and that is new. That is new with these guidelines, and that's why I put this question in there. Number 6, the definitive differentiator for hypertensive emergency. It is new or worsening target organ damage. And I do have a slide coming up that's going to get into each of those different things. Hypertensive emergency is when, I don't remember the criteria for the blood pressure numbers. It's on that slide. It's too many numbers in my brain. I'm not going to give you a wrong number, but it is that severely elevated blood pressure plus a symptom. If they're asymptomatic and it's elevated, you treat them outpatient. Number 7, which of these patients should go to the emergency department for hypertensive crisis? And that is the patient with the blood pressure of 185 over 115. He's 50 with new onset of chest pain or sudden shortness of breath. Those two, that chest pain or shortness of breath, those are your target organs. Those are the symptoms that you're looking for to send them to the emergency room. If he had no symptoms, that would be treated outpatient. Now, you might give him some meds and have him come back in 3-4 days. You know, if it's Friday, you might have him come back on Tuesday. If it's Monday, have him come back on Friday. You're going to follow him pretty closely because you want to bring that blood pressure down. But it's not such that it has to come down immediately. The patient number A, you know, all of these have the same blood pressures, but patient A, that first one, we know why his blood pressure is up. He didn't take his meds. So we're just going to restart the meds, probably have him come in for a recheck, make sure that he's good with his meds, and then remind him, we want to see how your meds are working. Take your medicine before you come to the appointment. Do you have patients that do that? We had patients that would do that. They wanted us to see what his blood pressure was. It's like, no, we want to see what it is with your medicine. There's some patient education there. Patient number 3, you know, that same high blood pressure reading, and he's got a headache, but it got better with Tylenol. Well, headache's not probably from the blood pressure if the Tylenol makes it better, so we're going to treat him as though he does not have a target organ symptom, and we're going to adjust his medications and do what we need to do to get that under control. And then our patient A, B, C, D, our patient D, 1, 2, 3, 4. He's 70, his blood pressure is way up there. Let him chill out in the clinic for a while. It doesn't do anything. He's not really having any symptoms. We're just going to adjust his meds and he's not going to be sent to the emergency room either. That is something that has changed in these new guidelines in order to prevent doing too quick of a reduction of that blood pressure on somebody who is otherwise stable. So Any thoughts? And anybody that got anything different than what I said was the right answer, this was a learning exercise. And like I said, when I made this, I had the book in front of me. And as I'm telling you the answers, I have my cheat sheet to make sure I remembered what I was learning as I did this. So this is all intended to be learning. Do not worry if you got anything different than what I said the new answers are, because we're learning the new guidelines. All right. So we'll move on. Is there anything in chat? Did we get any questions in?
No questions in chat.
All right, so I told you guys I would talk through some of those things behind those different tiers and answers of what we were looking through. So our non-pharmacological interventions, our lifestyle changes, those are defined now. And I would like to see, this is me telling you how to run your clinic, so take it for what it's worth. I would like to see health centers start giving patients guidance on, eat a healthy diet, exercise, lose some weight, come back in a year. Can we give them a little more guidance? Those of you that have that food as medicine program going on, I think that's an excellent use for this. Again, you guys run your clinics, not me. But if we want our patients to improve their lifestyle, it seems prudent to give them some resources, even if it's just some materials or handouts. Or, hey, go to this website or that website and get some information about how to do the DASH diet or the Mediterranean diet, or how to modify recipes to be lower in fat, that kind of thing. So these are what the official recommendations are. How this plays out with the new nutrition guidelines from the administration, I'm not quite sure. That whole thing seems odd. It doesn't seem like the pyramid should be sitting on the point. So it just takes me a minute to wrap my brain around how the new nutrition guideline goes. And so this is what, when the guidelines talk about non-pharmacologic interventions, or they talk about lifestyle changes, this is what that means. This is what that definition rolls into. So following up for stage 1 hypertension, it's a little bit more aggressive. They want those patients to do some home blood pressure checking, come back to the clinic more often for a reassessment. And if that blood pressure is still over 130, over 80 in 6 months, this is our, we're doing our lifestyle changes first group. If that's still not down below 130 over 80 in 6 months, then we do add that antihypertensive medication, which is a lot more aggressive than what we've thought of in the past. But the reason for that is because even at that level, that blood pressure, even being slightly elevated, is doing early damage to the heart and to the kidneys. And so that is the reason behind this. And we hear about prevention, and this is part of prevention. Lowering those target blood pressures is part of prevention of long-term cardiac disease, long-term kidney disease. So that's what these are. This is the, hey, slow down sign on the Curry Road. So this I put in a little bit of a table to make it just a little bit different view. And it does kind of split out low risk into, or excuse me, stage 1 into low and high risk. And that is the low risk prevent and the high risk prevent. And in our patient, in our question 1 and question 3, one was low risk, one was high risk. So that's where these are. Still seems strange to me to see elevated blood pressure at 120 over 80, over 120 or over 80. It's just that has been the target for so long. It seems odd. So I'm sure that there's going to be a learning curve for all of us and an even bigger learning curve for patients. Any thoughts? And then some of the vocabulary changes in the guidelines. I kind of mentioned it a minute ago, but hypertensive urgency, that used to be, hypertensive urgency, you go to the emergency room, they'll fix you. That is no longer a term at all in any way. It's a hypertensive crisis, but remember, it's only if there's an additional symptom. Otherwise, it's severe hypertension. And those patients with severe hypertension stay there at your health center to be managed. It's only the ones that are in hypertensive crisis who have both that very elevated blood pressure and a target organ that you're having symptoms for. So really the difference between the two is there another symptom? Another thing that's new is they put a lot more emphasis on kidney health. And the expectation is that there will be a urine creatinine to check for early chronic kidney disease or cardiac kidney metabolic disease. And so that is a new thing in the guidelines. Key changes, the prevent over the PCE or the ASCVD risk score. That's changed. There's online tool calculators for that prevent. I don't know that any of the EHRs have got that updated. Like I said, I don't know that the guidelines have even been out 6 months yet. I know that it's not updated in Azara. It's still just the ASCVD risk score that is calculated by Azara. So that is available. And the benefit of this for patients who do not already have symptoms of cardiovascular disease is that it is a larger pool. They have taken out race as a criteria in that calculation. And they are calculating it for I think it's a 10 and a 20-year risk score. So I think it's a shorter, too many numbers floating around in my head. But they've made it even more accurate for the older population. It's a little bit fuzzy on the younger population. And then keep in mind, this research was pooled on Americans, so it doesn't necessarily translate into other populations. Not quite sure what that means, but that's what the literature said, so I'm sharing that with you. The universal kidney screening, that's the new thing that these guidelines are really promoting is that kidney health, early monitoring for kidney health, and preventing early damage to the kidneys. And then no ER for asymptomatic severe hypertension. So those are some of the big things. And those might be some of the harder things to change because we've been in that habit. And it's like, well, if I don't send that patient, am I going to get sued? Or are they going to have a stroke? Well, are they having symptoms? We're just follow the guidelines, document to the guidelines. And I tend to not tell providers how to treat patients, but I educate them on what best practices and the whys behind it. So I understand we all have our lanes. So, but just that education, educate providers, educate staff, educate patients, and we'll get there. All right, we've talked about hypertensive crisis. When does the patient go to the emergency room? Here's our numbers. Greater than 180 or greater than 120. Does not have to be both. It can be one or the other. So these are the left-hand column. Let's see if my mouse can come over here. This left-hand column, these are when you send them. You know, they've got something going on neurological, they've got something going on cardiovascular, they got something going on with their eyes, they got something going on with their kidney output. Asymptomatic, they feel fine. You know why it's high because they missed their meds. Those are not crisis. Those are severe hypertension. All right, so I've talked a little bit about cardiac, kidney, metabolism, care, and how those are very interconnected. That's always been a thing, but it's even more more focused in these new guidelines. Hypertension is a key driver of the cardiac kidney metabolism disorder and causes damage across all the systems. And so I don't remember why I put SDOH screening in here, but that is, oh, that is part of the prevent. That should have been on an earlier slide. I am so sorry. But it also applies as watching and working to prevent cardiac kidney metabolism disease. I'm going to start going just a little bit faster because I have way more slides than I have time for. But this is just kind of a diagram of cardiovascular kidney metabolic disease or syndrome. I guess it's syndrome, not disease. My apologies. And this is really hard to read, trying to get in there and see all those little things. So I found us a cute little table that starts at stage 0, which pretty much stage 0, even the literature I was reading says youth and very young adults are pretty much the category that's in here. The rest of us have a little bit of something going on. So these are the 5 stages of cardiovascular kidney metabolic syndrome that hypertension drives. So I have slides for each one of those stages, stage 0 through 5, with what that stage is, and then the targets. I'm going to go through them fairly quickly because, like I said, we've got about 10 minutes left, and I want to give some time at the end for questions and to do the survey. So we're just going to go through pretty quickly. When you get these slides, this here is a link, the Life's Essential 8s. This is what they're recommending to promote to youth, young adults, your adolescents, this would be something good for them. And I'm pretty sure that if you're counseling on these, it hits all of the things for the adolescent BMI measure for, measuring the BMI and then doing counseling on activity and nutrition. The Essential 8 include both activity and nutrition and some other things. So that is a link that you can get. They've got diagrams and education tools as well. So these are the targets that qualify that are for stage 0. Stage 1, this is where there is excess adiposity or dysfunctional adiposity. And so we're looking at BMI, we're looking at waist circumference. We're also looking at, is there any impaired glucose? Do we have prediabetes? Do we have elevated fasting blood glucose? They don't have high blood pressure. They don't have high triglycerides. They don't have kidney disease. This is that waving flag. It's like, hey, slow down. Slow down. We might need to fix something here. We're gonna go off the rails. So these are some of the treatment guidelines for stage 1. Sometimes pharmacotherapy is indicated. They have found that the GLP-1s are very protective for the heart, I believe. And so it is definitely a recommendation in these guidelines to utilize those when indicated for long-term health. There's a lot of other things that goes into it, not just cost, but side effects, long-term, and pairing those with lifestyle change and support, not as a standalone. These are the stage 2 risk factors. They're not quite, they're like right on that line. They're kind of like, well, we've got a blood pressure over 130 over 80. we're in that stage 1. Our A1C is creeping up, our fasting glucose is creeping up. Our stuff is creeping up. Maybe we need to do something real quick. These are the guidelines to treatment. And here we're getting into some screening of metabolic and kidney markers. Stage 3 is subclinical. This is they do not have clinical cardiovascular disease, but evidence of disease without symptoms can be seen. These are the treatment guidelines for stage 3. And stage 4, we've tipped over into cardiovascular disease. And then there's substages with and without kidney failure. And the treatment guidelines. So these are some of the, I always plan too much for these. So I had planned to try to go through some thought planning for some driving some change in the health centers. I've got a little discussion worksheet that'll come with your stuff. It kind of gives, it's a Word doc, a PDF document. It's got maybe a page and a half of, do you do this? Have you thought about that? Just kind of some thought-provoking ideas that you can take back and have conversations within your health center to look and see what fits for right now for your health center to drive improvement in health. And so that this is about that discussion worksheet. So next steps, do we want to challenge you for a 90-day plan to come up with an aim for one driver to try 1 or 2 change ideas. So I even made you guys a possible timeline. So what do you think? We're past UDS. We haven't got into everybody on summer vacation yet. And we know when fall gets here, it's going to be flu shots and then flu season. So it's kind of like a really good time to try something. So I will leave you with that thought. And Carrie is going to put the survey in the chat. We've got about 5 minutes left. If you can do that survey, I really appreciate it. I do love your feedback. You give me guidance on where to go with these things. Tell me in our meetings. I really want to make these valuable for you guys. And I'm going to give you a minute or 2 to do that survey, and then you will get the algorithm, the treatment algorithm with the slide deck tomorrow. You will get a the thought idea conversation starter list as well. And then the recording. So if you have somebody that you want to listen to me ramble on, feel free to share. If you want to get together and talk through some stuff, I absolutely am available for that. Talk through things, find resources for you. If you want to have a further conversation around any of these things, if you find anything that challenges anything I've said, absolutely do not let me misinform somebody. If there's something out there that I've misinterpreted, absolutely. I'm always open to that. And that's all I have for you guys. I really appreciate you coming today. I really appreciate your feedback, and we'll talk to you again soon.